Um, okay, well, I think we'll just get started. So, welcome, good morning, and good afternoon to everyone. Thank you so much for joining us today. My name is Priya Raman. My pronouns are she, hers. I'm the CAPE 3 program coordinator here at the Asian Pacific Partners for Empowerment, Advocacy, and Leadership, also known as APPEAL, and I will be facilitating our inaugural Breathe Free briefing today. Before we get started, I thought we'd take a moment to recognize our ancestors and our Indigenous communities. And we recognize that we all have and benefit from the occupation of the lands that we are on today. Um, so we'll just take a minute to just remember them. And just a quick reminder, as participants of this webinar today, you are all muted, so please use the chat box to chat with our team and also to write in any Q&As that you may have for our panelists. If we are not able to get to questions today, we will send out some follow-up information in the next couple of days. And if you need support with that, the chat box is the one with the little square and it says the word chat under there. So you can drop your messages in there. Um, I'll be taking just a minute to quickly introduce our panelists for today, but you can also read their full bios on the registration page, which I'm going to drop in the chat for you all. So you can pull that up if you want to follow along. So we're going to start with our first panelist today. On our panel today, we have Rod Liu, who is the founder and executive director of APPEAL, the Asian Pacific Partners for Empowerment, Advocacy, and Leadership. Rod was previously the health education director at Asian Health Services and the associate director for Association of Asian Pacific Community Health Organizations. Rod was the contributing author to the 1998 Surgeon General's report on tobacco use and has published widely on commercial tobacco and health disparities. Rod serves on numerous national health advisory committees and has received the Christopher Jenkins Cancer Control Award in 2002 and the Lester Breslow Lifetime Achievement Award from his alma mater, UCLA School of Public Health. The next person on our panel is Richard Calvin Chang. Calvin is a Native Hawaiian attorney who co-founded and currently serves as a director of the Native Hawaiian and Pacific Islander Data Policy Lab at UCLA Center for Health Policy Research. Calvin has over a decade of experience working with the NHPI community and managing policy campaigns that address NHPI health disparities and promote data equity. He co-authored demographic profiles on the NHPIs in the US and California, and the first policy platform blueprint for NHPIs in the United States. He also recently co-authored the first NHPI data policy platform and is currently working on projects that include a data curriculum for community organizations developing accessible data tools and supporting inclusive and equitable data policies. Calvin received his JD from Seton Hall University School of Law and MS in Computational Analysis and Public Policy from the University of Chicago Harris School of Public Policy. He was also appointed for the U.S. Census Bureau's National Advisory Committee on Racial, Ethnic, and Other Populations in 2021. Next on our panel, we have Dr. Tu Quach. Dr. Quach is the president of Asian Health Services, a federally qualified health center in Northern California, serving 50,000 patients in English and 14 languages. Using her background in epidemiology to work on countless projects related to research and policy efforts, emphasizing the importance of language justice, data disaggregation, and mental health. Dr. Quach has expanded culturally and linguistically responsive mental health services at Asian Health Services. She currently serves as a board chair for APCHO and is appointed on the Alameda County Behavioral Health Advisory Board, along with other various boards and councils. Dr. Quach received her Bachelor's of Arts at UC Berkeley, her Master's in Public Health at UCLA, and her PhD in Epidemiology at UC Berkeley. Last but not least, we have Uriah Blackwell. Uriah is a half-Black, half-Kanaka man born and raised in Hanford, California. As a community engagement coordinator for Central Valley Pacific Islander Alliance, also better known as CVPIA, Uriah works with communities throughout the Central Valley to help build equity through community events, programs, while also providing advocacy by representing Pacific Islanders in the Central Valley in spaces such as this. He is also involved with the Southern California Pacific Islander Community Response Team, or also known as SoCal PICRT, the Black Pacific Alliance, UCLA Pacific Islander Alumni Association, and Spark Leadership Fellows, and many, many more. And with that, I will pass it over to our first panelist.
Thank you, Priya. On behalf of Appeal, I would like to thank everyone for joining today's inaugural launch of Breathe Free Day. For 30 years, Appeal has been working to address tobacco-related disparities for Native Hawaiian, Pacific Islander, Asian American, and other party populations. It is time for a day specifically focused on how commercial tobacco has impacted our diverse Native Hawaiian, Pacific Islander, and Asian American communities. And we are dedicating today, May 1st, as Breathe Free Day. We've known for a long time that when data is disaggregated properly, both NHPI and Asian American subgroups have higher rates of smoking than the general population. This is true nationally, as well as in the state of California, where smoking rates have tended to be lower. Breathe Free is about being free from the smoke that comes from tobacco and cigarettes, but it's also being free to have a life free of tobacco-related burdens. Breathe Free is about being free from the health impacts that are incurred, $225 billion that are spent on healthcare costs related to tobacco-related diseases. Breathe Free is about being free from the burden economically of $150 billion due to lost productivity. And Breathe Free is about being free from the many burdens of tobacco-related disease that are caused in our lives and those of our families and communities. It is not a coincidence that today, Breathe Free Day, falls on the first day of Asian Pacific Heritage Month. It is somewhat ironic that when we look at the history of tobacco use in our communities, there is a great role of the tobacco industry that has targeted both Native Hawaiian, Pacific Islander, and Asian American communities and other communities with their deadly products. This includes menthol, and while we were also disappointed that the ban on menthol was not upheld, we continue to fight for addressing the targeting that the tobacco industry has done in our communities. We also recognize that the tobacco industry has used our own heritage to promote those deadly products, including campaigns in the past such as Kauai Colada, and also promoting flavors from cultural foods such as mango and lychee with e-cigarette promotions. We need to preserve our cultural heritage, and that is why we are dedicating today to Breathe Free Day. But our heritage is also tied to perseverance and overcoming the struggles that we've faced with many disparities and inequities. And tobacco control is no different. There have been many successful stories of individuals from our communities and our communities fighting back to not only counter the tobacco industry targeting, but to help to pass supportive policies that can ensure greater tobacco control for our communities. And this has included both communities and young people in our communities that have been fighting for these issues. So today, for those of you who are burdened by commercial tobacco, we would like you to use this day for reflection on the impact and to seek cessation services. For those of you who speak Cantonese, Mandarin, Korean, or Vietnamese, we are lucky to have the Asian Smokers Quit Line, a national quit line dedicated in language for those 4 groups. For other groups, we continue to advocate for greater culturally tailored services on cessation so that we can properly address this issue. We recognize that addiction is hard, and so we also ask that family members continue to support those who are tobacco users to be able to give up a tobacco habit. We want communities to take a greater stand against tobacco, and so we ask many of our other partners across the country to also dedicate Breathe Free Day for your organizations. And particularly, we ask systems and policymakers to recognize that Native Hawaiian, Pacific Islanders, and Asian Americans indeed have a commercial tobacco use issue and that we need greater resources to better address this issue for our communities. Breathe Free Day will launch a month-wide list of activities, including webinars and vignettes, stories, if you will, about how our communities have fought against tobacco disparities. We dedicate this day to those who have family members who've been lost due to tobacco-related diseases, but also to those who have worked tirelessly to help someone with a tobacco-related disease, whether it's in a health center or a hospital or an advocate, including those who have fought for lung cancer and lung cancer screening. We believe that to be breathe free is to live free. And with this, we celebrate our very first Breathe Free Day 2024. Thank you again for being here. And I will now turn it over to Mr. Calvin Chang.
Aloha mai kako, and mahalo to Appeal for the opportunity to be on this panel. A lot of us have stories of family members who've unfortunately smoked and paid the price. I myself have 3 uncles who are heavy smokers, and 2 of them ended up getting cancer. The only members of my family that got cancer. And the 3rd uncle, who is a heavy smoker, had a debilitating stroke recently. We also know that tobacco products are so insidious that you don't even have to be a smoker for it to affect you. A 4th uncle of mine who never smoked worked long hours at a law firm where everyone else smoked, and he passed away from lung cancer in his 50s. What helps elevate these stories from being individual experiences to events that represent the broader community is data. Data is the language that policymakers and health agencies speak and utilize when they make decisions and decide whether to give our communities resources that'll help us address tobacco-related problems. And there's no doubt that tobacco products and the tobacco industry continue to harm Native Hawaiians and Pacific Islanders. According to a survey conducted by SAMHSA, 15% of NHPIs in the US aged 12 years and older have smoked cigarettes in the past month. In the NHPI community, 157,000 adults have vaped in the past year. Could my slide be displayed? Thank you. The UCLA Center for Health Policy Research also conducted an NHPI tobacco survey of over 1,200 NHPIs in California and found that nearly 2 in 3 NHPI adults were currently using tobacco products. That's quite a large share. And half of the folks surveyed said they would prefer to receive cessation services from an NHPI serving health organization. There's also high exposure to secondhand smoke on sidewalks, in homes, and where they work. But there is some light at the end of the tunnel with some additional data that on opinions that they shared regarding policies that they would support that would help address these issues that I'll share in a bit. But this report can be accessed at the UCLA Center for Health Policy Research's website. This slide can be closed. So tobacco companies haven't stopped targeting our youth either. An estimated 7,000 NHPI minors vaped in the last year. Researchers have also found that 45%, nearly half of NHPI middle and high school students, have reported trying tobacco products. And these statistics are concerning because the leading causes of death for the NHPI community, according to the CDC, have been COVID-19, heart disease, and cancer in the past few years. And these are all conditions that could be caused by or exacerbated by tobacco products. Tobacco products also have implications for our environment. Cigarette filters are the #1 most littered item in the world, and they're made of plastic which won't biodegrade and can leach chemicals into the water, where they can be absorbed by marine life. However, as I said, there is some reason for hope. The percent of NHPI smokers dropped from 22% 6 years ago to 15% now. There's definitely room for improvement, but this represents substantial progress. There's also widespread agreement on anti-tobacco policies that we found in UCLA's Center for Health Policy Research survey, which found that 3 in 4 NHPI adults in California agree on a tobacco sales ban to anyone born after 2025. And more than 4 in 5 NHPIs agree that apartment units should be smoke and vape free. What's needed now are more resources to continue studying effective ways of encouraging tobacco cessation, and this requires collecting data that relates specifically to NHPI communities. A lot of the programs that currently exist don't take into account our cultural values or historical trauma that may lead to greater stress, which is in turn associated with greater tobacco use. Health departments need to collect and report tobacco-related data in our communities so that we have a baseline for measuring progress and to help us develop effective cessation programs. Community organizations should also be supported in their efforts to develop these cessation programs that are specifically tailored for our communities. Mahalo for the opportunity to speak.
Next, we'll pass it to Dr. Quach.
Thanks so much to Appeal for inviting me to be part of this important public health endeavor. I have had the great honor and pleasure working at Asian Health Services, a federally qualified health center founded exactly 50 years ago by UC Berkeley students who saw that their own family members in Oakland, Chinatown were unable to get health care due to income and language barriers. Today, we serve 50,000 patients, providing robust medical, dental, and behavioral health services in 14 Asian languages. With our two pillars of service and advocacy, we pride ourselves on providing and advocating for culturally and linguistically responsive care to our diverse patients. A vast majority of our patients are low income, limited English proficient, and are immigrants or refugees who have faced past migration trauma. Over the recent decades, while there have been significant strides in tobacco control, we still see high rates of smoking among our patients, particularly our male patients. Among our patients, we see that the smoking prevalence is 23% among male patients compared to about 14.7% in California. When we disaggregate the data, we see that there are groups that have even higher rates. Among our Vietnamese male patients, we see 1 in 4 are current smokers. We also see that 40% have been past smokers who have quit smoking. So altogether 65% of our Vietnamese patients, male patients, have at one time or another been a regular smoker. Why the high rate of smoking in our communities? The quick answer is that they fit the demographic that we often see are susceptible to adopting smoking behaviors. Low income, low education, limited English proficient, being Asian, and being targeted by the tobacco company for profits. The list goes on. But I'd like to just personalize those statistics for just a little bit. For a brief moment, I wanted to put one face to those numbers of the typical smoker. If you can pull up my slide really quickly. This is a photo of my mom and dad when our family first arrived in the US after escaping Vietnam. My dad grew up very poor in Vietnam, raised by his grandmother without parental figures growing up. He never finished grade school before starting to live on his own, surviving the rough streets along with other teenage boys. He met my mom at a young age, and they eventually started a family. As the war in Vietnam took its course, my dad was recruited by the US CIA to help fight against the Northern Vietnamese communists. The CIA often recruited poor young men at that time, paying them a few dollars a week to do the work. Yesterday, April 30th, marked the 49th anniversary of the fall of Saigon. On that day, my dad made a split-second decision not to leave Vietnam and stay behind with his wife and three very young children, including myself, who were not able to leave on that day. Years later, our family of 5 would escape on a small fishing boat, live in refugee camps before resettling in the US. We came to the US with no money and no promise of a better future. My dad learned to become an auto mechanic and provided for his wife and kids. Both my mom and my dad, who are no longer here today, survived poverty, war, and resettlement. At an early age, my dad started smoking and became a heavy smoker when we first came to the US. The lifetime of stress, the endless discrimination he faced as a young child and throughout his adult life, and the other social determinants of health contribute to his dependency on nicotine. It was only when my mom became pregnant with my younger brother and the doctor shared about the harms of secondhand smoking that my dad decided to quit. Despite the demographics and the many years of smoking, it was the knowledge of the harm it would cause his family that motivated him to quit. You can take down the slide now. My dad's story is probably not too uncommon among Vietnamese men. But what it underscores is the importance of understanding one's full life course, the circumstances that impact one's decision, and identifying what motivates them to change. My dad's story is one of resilience and of love. Stories like my dad is what helped inform Asian Health Services to work with UCSF researchers like Dr. Janice So and Dr. Tung Nguyen years ago to design interventions that would be effective in convincing Vietnamese and Korean male patients to quit smoking. It is about centering our patients, understanding what they've been through, and designing public health practice that makes sense to them. After many focus groups, interviews, and pilot testing, we designed an in-language messaging from our doctors tailored to the cultural values that matter to our patients, such as the health and well-being of their family. Our results show that culturally and linguistically responsive interventions that center the family health was the most well-received and effective at getting our male patients to start considering quitting. As I was asked to share a healthcare perspective, I can emphasize 3 things that are essential in helping our communities breathe free. Policies and public health interventions must consider these 3 essential factors. Collect and utilize data that not only disaggregate, but also show our communities in their full humanity. 2, language access impacts how information is received by our patients. And 3, cultural values is often a key driver in how our communities respond and adopt to life-altering changes. As we kick off the month of May as AANHPI Heritage Month, I want to thank all of you for centering the work on our communities and celebrating our collective strength and resiliency. Thank you.
Thank you. And next, we're going to pass it to Uriah.
Good morning, everybody. Thank you, Appeal, for allowing me this opportunity to be here and speak. And I also want to thank the fellow panelists for being here. I'm honored to be sitting here and listening to your stories and also learning more about the statistics coming around cessation within our communities. Hello, everybody. My name is Uriah Blackwell. I'm here representing Central Valley Pacific Islander Alliance, better known as CVPIA, a community-based organization that began April 28th, 2021. So that is 3 years ago, almost exactly, when a group of like-minded Pacific Islander leaders came together to help put together one of the first Pacific Islander-led COVID-19 vaccination clinics in the Central Valley. From there, we've ingratiated ourselves in the Central Valley community and began to see that there are many other issues rather than just COVID-19 that plague our communities. One of the big ones being tobacco use. As we've ingratiated ourselves in the community, we began to realize that a lot of the stories that we face as Pacific Islanders are relevant to other communities as well. Things like advertisements, so tobacco products being very prevalent in cartoons, marketing, and just our daily lives. Things like liquor stores selling them on every corner, them being seen at every stop, every gas station, every grocery store. Those are things that we can't unsee. Those are things that we see every day and things that are normalized in our society. Beyond that, we also recognize that secondhand smoke is something that is very prevalent in Pacific Islander communities, as the data has shown that Calvin was so graciously giving us earlier today. Pacific Islanders on average live in multi-familial living arrangements, meaning that there are oftentimes many families living in one home. Because of that, the rates of smoking in each household is higher than most. Not only that, but most Pacific Islanders have a brief or current background in military use where tobacco use is also very rampant as well. Because of that, a lot of Pacific Islander youth or those that don't smoke at all still have to deal with the ramifications of those who do because of secondhand smoke. Beyond that, it is also not an uncommon occurrence for it to be passed down through culture, media, or oftentimes friends and family. Because of that, as a community organizer, we're here to ask that as we push through Asian Pacific Islander Heritage Month, that there be more funding and also more awareness around culturally relevant, language-specific, and also trusted messengers to apply more cessation policy throughout communities, not just in the Central Valley, but throughout the nation and Asian and Pacific Islander communities. We hope that this awareness and the ability to showcase our statistics and also leaders like we are today is able to help push our, our overall awareness and getting more cessation policy in our communities. So thank you for everyone who is here today, and thank you for giving me this opportunity to speak.
Yes, thank you so much to all our panelists for the amazing stories, and thank you so much for sharing your experiences and talking a little bit more about how tobacco is impacting our AA and NHPI communities. As we begin to wrap up this briefing today, I just want to remind you all this briefing is a kickoff to a month-long awareness campaign like Rod mentioned. So we will be having other various events happening across the month, whether that's webinars, some vignettes, which will be on our social media pages. And we just want to make sure that you all can access those. So I'm going to have our team drop in the chat some of our social media pages so that you all can follow those to follow along with that, as well as please join our listserv so that way you'll know more about the other opportunities that are coming up at Appeal, including we are actually hosting a leadership training happening in early June, so June 4th through the 7th in Washington, D.C. And that actually went out on our listserv and was also posted all over our social media. But we are still accepting applications till tonight. So 11:59 p.m. PST is the deadline. So please feel free to check that out as well. And as we, wrap up today, I just want to take the time to, again, thank our panelists. Thank you so much for taking that time out to join us today. And I just also want to give a huge shout out to our appeal team who have been working behind the scenes and organizing this briefing and all the other events that are going to be happening this month. And yeah, thank you so much for joining us.